Welcome to Influence Interviews. Today, my guest is Theresa Sheppard. If you are a dentist or on a dental team, Theresa has some incredible insight to protect the practice and provider from audit, lawsuit, and frankly, risk of incarceration. Her standalone service, SnapShots Prevent MugShots, is all about proper documentation and claim narratives to mitigate risk. She's been in the industry for decades and is an expert in not only fraud prevention, but getting more money back into the practice by coding properly. She knows patient records must be documented thoroughly to meet the standard of care. I am so excited to introduce Theresa Sheppard to you. Theresa, you have a wealth of knowledge and an extensive background in the dentistry industry. Please share with us how you got started.
Thanks, Laura. I appreciate the invite today. Yeah, I've been in dentistry a few decades. That my age is hanging out, so that's a little bit difficult for me to kind of spit those words out. But I started out as a chairside dental assistant, and I chairsided for about 10 years. Loved dentistry, but as you know, happens sometimes with chairsiding, we start to develop some wrist problems and things like that. And I was looking into what my alternatives were. And I had an opportunity to work in the front office area of a small private practice. I subbed for a gal that was going on maternity leave. And from that, I ended up managing that practice for over 23 years.
Wow.
And so I have a lot of experience in managing. It was a very small practice, 2 operatories, and not booked out more than just a few days at a time. And I had come from chairsiding from a higher end practice that the doctor was very proactive, spent a lot on, educating his team members. And so things just weren't matching up for me. I didn't know that everybody wasn't the same. And so I started asking if I could incorporate certain things, and over the years, we went from the 2 operatories to 5 operatories and 2 hygienists and booked out, and the revenue increased. And so that was always interesting to me. I love finding that and making things work properly. I also have a passion for teaching. And so I wrote some curriculum and opened a dental assisting school and taught that for a period of time. I'm a California continuing education and radiation safety course instructor. And gosh, what else? Let's see. In 2019, I opened a teledentistry company. So I love dentistry. I love every aspect of dentistry. The 2 things that I am most passionate about are risk management, of course, and oral systemic link. So we really need to, and both of those go together. Everything is intertwined in a dental practice, in any healthcare. You can't have one thing without the other.
I agree. Well, congratulations on an amazing, extensive career.
Just kind of evolved,
Yeah.
I'm the perpetual but why girl. I want to find out why we do things. What can we do better? How can we educate and improve ourselves? And I just love learning. So there's always something new.
Oh, there always is. And I expect that at the end of this interview, our audience is going to learn a lot from you, because I have definitely learned so much from you on both of those 2 passions, especially because you got me really excited and really thinking about how they are correlated. Let's go back to the first, where we're talking about, mugshots prevent, or SnapShots Prevent MugShots. Talk a little bit about how that came to be and how that service, how it works. Tell us more.
Yeah, so in teaching risk management and providing CE courses for that and things like that, I started getting asked to, come into practices and look at their documentation. I would have people come up to me after CE courses and say, hey, is there any way you could tell me if I'm doing okay or whatnot? First thing I have to make sure everybody understands is I am not an attorney and I do not give legal advice. The advice I give is contact your attorney. Okay, but I do know what constitutes risk and what can pose a risk in a practice. And so I was kind of repeatedly asked, hey, can you just check out my stuff? Do you think we're doing okay? And so from that is how SnapShots Prevent MugShots evolved. It wasn't something I woke up one day and say, I need to do this program. It's actually just a standalone service. And what I do is I remote in to a patient or a practice, and I work for about 20 hours. And I just kind of start with a random day on the schedule, start with the 8 o'clock patient, and I open that up and I go down rabbit hole after rabbit hole after rabbit hole. And I'm looking at the documentation. I'm looking at the x-rays. I'm looking to make sure everything matches. If you said you did a service, how are you backing that up? Are we coding properly for that service? I see tremendous risk for practices that are not coding and delivering periodontal service care properly. I look and make sure our forms are filled out correctly. Are we, if we're providers for insurance companies, especially, are our adjustments being done correctly? Are we adjusting off too much? Are we giving too many discounts? And the thing is, I have a lot of doctors say, well, it's my practice. If I want to give someone a discount, I will. Mm-hmm. I'm like, I agree 100%. It is your practice. And if you want to give your brother-in-law a courtesy off of his copay, I'm all for that. But if they are insured, you must disclose that to the insurance company. Mm-hmm. And the reason for that is because when you're submitting a claim, that is being represented by what your full fee is. And if you submitted a claim, let's say for $100, and the patient's copay was $20, and you didn't charge that copay $20, your fee is not $100. Your fee is $80. And you have to disclose that to the insurance company. Then they're going to pay their 80% of $80. So you really lost $40, not $20. People think I'm just writing off a $20 copay. Right. If you're doing it legally and properly, you're losing much more than that. So again, I'm not saying don't, help out your brother-in-law or offer them that courtesy, but sometimes there's other ways to do it. So many people are providing the services. They're not getting paid for it because they're not coding properly. And perio is the biggest thing that I see, and one of the biggest areas that doctors get sued for.
Okay. Do you think is there not proper training coming out of schooling, or is it just because the insurance coding practices change, or what? Or are they not properly training their staff? Where is the biggest opportunity for you to help their team get up to speed on proper coding practices?
I think all three of those things factor in, because one is in dental school, and any dentist out there is going to tell me they've heard this a million times. You're not trained to run a practice. Right. You may have perfect feather margins on that crown. You may have the latest, greatest CAD/CAM machines and everything, and be the best clinical dentist on the planet, but you don't know how to run a practice. They didn't teach you that. Mm-hmm. Maybe 2 hours of, the last day before you graduate kind of a thing. They really don't. And that's such a disservice. Yes. Because people get in and they're truly lost. They depend on, maybe they've taken over a practice from a doctor that's retired, and they've kept the staff, and the team members that are there have been doing it the same way for 15 years because that's the way they do it. Right. That's the way they were taught. And maybe that's not accurate now. Things do change, things do evolve. So that's one thing is doctors don't know what they don't know. Team members don't know what they don't know. So there's always education to be had by everyone.
Yeah, we cannot be an expert in all things. And that's why I love your focus of expertise. But the other part I love, not only do you have a focus of expertise, but you've been exposed to all of it during your career. And so
I've sat in a lot of chairs.
Yes, so you have a particular insight that I think is pretty special for those who get to work with you.
Well, thank you. And that's one of the reasons that I do continue to teach and love to teach, because I have sat in many chairs and I understand the risks that each position faces. I understand the challenge that each position faces. I understand the relationship between the clinical and the admin team, and that sometimes is a rocky one.
Yes.
And it doesn't have to be, but it's just all about education and preparation. Another thing is what I see when I go in and I do a snapshot for a practice. The insurance breakdowns that people get are kind of, they're not asking the right questions on them often. I see for sure they're eligible, what the frequencies are, things like that, but there's very specific questions that really need to be asked, particularly when it comes to their perio benefit. Now, I'm the first one to tell you that we should not let insurance companies dictate treatment. And they like to do that.
Yes, they do.
And I'm also the first one to tell you patients should not be dictating treatment. They like to do that too. And they do that because it's based on finances. If my insurance doesn't pay for this, then it's not necessary. And that's kind of the tone that the benefit plans set. And it's really not even true insurance in the bigger scheme of things. Insurance is when you have a problem and you've got coverage for it. And dental benefits aren't like that. I mean, I haven't seen plan maximums over across a broad spectrum go up in 30, 40 years.
Right, right.
You know, many plans still have $1,500 a calendar year, 2 pro fees, well, we don't cover this, we don't cover that, then it's not insurance. I'd rather see patients not buy into that and get into an in-house plan of some sort if your dentist offers that, because it's a lot more flexible, and that's a whole other interview. But that's a great way to get the treatment that you need. Treatment is between a patient and the doctor. And what we forget, our dentists are oral physicians. And patients forget that, or they don't have a recognition of that because it's, just my teeth, it's just the dentist. And many dentists forget that too, because they are kind of tied up in this dilemma of, if I don't kind of do what I'm supposed to do, what the insurance tells me to do, or what my patient tells me to do, I'm going to lose that patient, I'm going to lose production. And, I understand that. That is a big dilemma. So what I try to teach them during the snapshot, and I find these things, I try to teach the doctors, you can still provide these services. Treat the patient's condition, because I always find that it's easier to explain on the front end and educate on the front end and try and explain on the back end. And kind of circling back a little bit to the breakdown, I see a lot of times practices writing off root cleaning fees and copays because the patient got upset because they got a bill for, $80, let's say, for a copay for a couple quads of root planing, when their cleanings are free. So they don't understand. Well, if they don't understand, then you're not educating them properly. Right. And there are people that, I don't want doctors taking offense at that, because I know what they're going to say. Well, we always tell our patients. And yes, you do. But there's a difference between sitting at the chair side and going, oh, you need a deep cleaning, which that word should never be in your vocabulary. It does confuse the patient. oh, well, my cleanings are free. Why do I? And it sounds optional. Do you want to do the deep cleaning or do you want to just do the regular cleaning? It sounds to me like you go and buy a car. You want leather seats with that, or do you just want what it comes? It sounds like an optional upgrade,
Right.
and
Right.
it's not. You're treating a disease that the patient has. You have no control over what that patient shows up to your practice with. I mean, would a cardiologist, take responsibility for their patient's blockages and say, my insurance is only going to pay for one bypass, doc. Can you just do one and maybe leave the others? Can we do that? Or can you just give me a pill? Not do that. That cardiologist is not going to take that risk. They're going to go, yeah, I'm not, no.
No, they're going to give the best.
This is the disease that you have. This is the treatment for the disease. If you are not comfortable with me doing that for you, I'm okay with that. Find someone that will neglect you. Because that's not going to be me.
I think you're right, though. There is a mentality around dentistry. What is the minimum you can get away with, so that you don't have out of pocket. But and maybe that's true a little bit on the medical side. I don't know. I think we're probably all somewhat neglectful of our bodies and our care. But I think you're right. I don't know that I've ever really been educated, sitting in the chair as a patient, being educated about what really is the best. It does oftentimes feel like what you're saying, that optional upgrade. And it's a luxury item rather than a must have for really
a treatment for a disease. Right. So that's really, that and oral cancer evaluations are really some of the two biggest things I see that put a practice at risk. So I see documentation all the time where a patient, the documentation maybe from the hygienist will say heavy calculus, heavy bleeding, or even moderate bleeding, moderate plaque, moderate calculus, and they did a prophy. Okay, that prophies are typically for patients that are disease-free. Blood is not normal. Okay? If you're bleeding from your eyeball, not normal. And that would be something that you would, why is this bleeding? You would address that. Okay? You wouldn't go to the ophthalmologist and have them say, well, we can rinse it out, or we can actually cauterize and stop the bleeding and treat the, disease that you have. It's just, it kind of gets frustrating because I see it time and time again. And what happens is they're doing these bloody prophies, which there is no such thing. And they're not addressing the periodontal disease. And then the first thing I do once I see that, I pop over to the patient's health history, diabetic, on insulin or on metformin. The numbers are high. We don't know. Do we ever ask that? I see very little health history, actual conversations being documented with the patient. I just see health history, no changes. No changes from what? Especially a new patient. New patient, health history, no changes. From what?
We're good.
Yeah.
I don't know what they were, but we're good.
Yeah, the oral systemic link is a very real thing.
I want you to talk about this a little bit more, because the first conversation I had with you around this, my head kind of exploded. So please share.
Yeah.
Go into it. I love it.
This is like a 4-hour CE course. So I'm going to give you real quick the cliff notes. So oral systemic link is real. Okay. And lack of oral care is a real detriment to our health, because the pathogens that are in our oral cavity, we have hundreds, but there are 4 that are particularly deadly. And when I say deadly, I really don't say that lightly, because they're causing and contributing to some pretty serious diseases: cancer, Alzheimer's disease, diabetics have a huge, serious bidirectional link with periodontal disease and diabetes. So if there's one, there's almost always the other. If you have a patient that, let's say they come in and they've got some pockets and they've got a little bit of hemo, their tissue's kind of in rough shape, but not like terrible shape, advanced. And they say, yeah, I was just diagnosed as being diabetic, but my doctor said, it's not a big deal, watch my diet. You know, he gave me a pill to take every day. And you're seeing them, okay, right then and there's your first opportunity to educate. Ask them what their numbers were. What was your blood sugar this morning? Did we write that down? No, never.
Right.
Maybe we see them in 6 months because we're giving them this much time to get their bloody prophy and bloody tissue under control. Okay. Well, it's worse next time. Health history update, no changes. But maybe there was a change because now they're on injectables because their blood sugars are still out of control. You are diabetic or you know anybody that's a diabetic, and we all do, because it's rampant. We understand that diabetics don't heal well.
Right.
That's why they lose limbs, is because the infection just is out of control. Infections increase blood sugar. Increased blood sugar makes it harder for the body to fight an infection. So that's why I say the bidirectional link between periodontal disease and diabetes is really one of the most serious ones that there are.
And if
So
you're not
if
talking
we don't
about
get,
this, I mean,
doctors don't recommend it. They don't. Your physician doesn't. Your sometimes your dentist will, and sometimes they don't. But the person that I get irritated with the most is your actual primary care physician. Granted, sometimes we do see our dentist more often than we do our primary care physician. So that is even more of a sense of urgency and moral and ethical obligation to understand what's going on with our patients. If you're looking in a patient's mouth and they're a mess like that, and maybe they're overweight, maybe you kind of get a sense that this could possibly be a diabetic patient, or maybe there's another issue. Are we referring them back to their physician? Are we picking up the phone and having a conversation with their physician? No. Okay, see you in 6 months. You know, that part just frustrates me to no end, because we're putting our licenses and our practices at risk for supervised neglect. And sometimes
I
even
love that wording, supervised neglect.
that's exactly what it is. We're continuing to let the patient dictate treatment and not treat the disease. So the reply I get when I ask about that, you know, is, well, we had the patient sign a refusal. Okay, good. Patients can sign refusals all day long, and you should have a patient sign a refusal if they refuse treatment. But not, oh, I'm refusing x-rays, but I want you to do my root canal anyway. You can't do something less than, or something that's below the standard of care. If they don't want their root planings and they sign a refusal for that, great. Don't prophy them. They're not a prophy patient necessarily. Again, I'm not trying to diagnose. I don't have any, but I'm not licensed to diagnose anyway, but this is what I'm seeing based on my experience of years of teaching and really getting into this oral systemic link and understanding the perio and doing all these snapshots and looking at these x-rays with this bone loss and looking at these photos that are so bloody you can barely see a tooth. This is what is happening. We're prophying our perio patients. We're not referring when we should. We're allowing patients to dictate treatment. We're not documenting noncompliance. Noncompliance is a big deal. It sets, if we don't document every time a patient is noncompliant, and noncompliant can mean told them, you know, for the last 3.5 years that they've got cavities, they need this treatment, they need this perio, and all we're doing is seeing them every 6 months for a prophy, supervised neglect.
Yeah. Interesting. So
I see, yeah, I mean, and another thing that I see a lot of in terms of where a practice could run into a bit of trouble are the exams and the x-rays. Because I have seen, again, sometimes 2, sometimes 3 years will go by and the doctor has not done an examination on a patient. But yet we're profiling them every 6 months. We took x-rays. Who ordered that? The doctor has to determine the recall interval. The doctor has to order x-rays. Only the doctor can order the x-rays. The doctor can view those x-rays, diagnose, and treatment plan. So who ordered them? Who's viewing them? And many times the practice has a mechanism for that. You know, the doctor has reviewed the chart perhaps and said, yes, go ahead and take these, but that's not written down anywhere. And if you didn't, you know, write it down, you didn't see it, you didn't say it, it didn't need to be done, you didn't do it, and it didn't happen. Plain and simple.
do you have something that you give to your docs with kind of a checklist of the things that you cover in your snapshot?
I actually don't have so much of a written document that I send them. What I do is I have a complimentary phone consultation or a Zoom for a few minutes when a doctor has a question and they're considering, you know, because even though the main things that I see are the same, every practice is different. You know, I want to know, you know, how many doctors you have in the practice, who does the route split. Preparation is a huge thing. Yeah. I don't have time to do routes. Okay. You know, and then they end up writing off a whole fee for a crown or root planing because it wasn't a benefit, because we researched that enough, because we didn't start everything is connected. You cannot possibly have one thing in the practice regardless without the other. And so everything comes back to, what do I need to do? Do I have procedures, protocols? I can't just decide on a whim that this is what my new protocol for that is. And if you do, that's okay, because it's usually based on a reason for that. But you have to have good, solid practice management documents and written protocol and procedures. And I should be able to walk in your practice tomorrow and take over for someone that's on maternity leave and read that document and know what to do.
How often do you think that happens?
Never.
Thank you. And that's
5%. I shouldn't say never, because there's doctors that are going to go, hey, wait a minute, I spent, you know, $30,000 on a consultant to set me up for that.
Yeah, it's rare though. And it's even,
but that's not always the case.
Right. And even those who have used consultants, managing that through changes, employee changes, like actually having training to those practices and protocols so that they continue. Right. It's a lot of work.
Yes,
I think
it is. Yeah, and it's a moving target. Mm-hmm. It's constantly evolving. So what I typically will do is kind of going back to the questionnaire question is I have this conversation with the doctor. And if they are in a position where they would like for me to do a snapshot, we'll set that up and I'll do that. And then once I'm done with that snapshot, I have a very lengthy report, detailed report of everything that I have found during that. We get on a Zoom call and I go through that report.
Love it.
And then with that findings, I have recommendations. Mm-hmm. You know, maybe coding is their issue. Maybe they're either coding incorrectly, which could be considered fraud, on the larger scale of things, if you're providing one service and you're coding for another. And it's, again, it's not intentional. It just happens.
Right.
So, those are the kinds of things I look out for. What's matching? And can I prove it? The diagnosis. So we go through this recommendations and findings. I talk about treatment options, and I kind of go through this process as a doctor would be with a patient. So my first conversation with a doctor is triage. Okay, so I'm on the phone with the new patient. When did the tooth start hurting? How long has it been broken? What are you doing for it? So triage, and then the snapshots I view as a diagnostic. Okay, and then the report of recommendations, findings, the treatment plan, and the consultation. And then we execute treatment if necessary, which comes in the form of training. I've had offices where I've done a 2-hour one-time training with them, and they're good to go because they're really doing very well. There's just a little bit here, a little bit there. Just a reminder. Awesome. And then there's others where I've had 2 hours a week for weeks and weeks and weeks because I've had so much that we've had to chunk up into very small pieces and go through that. So every practice is different.
I just feel like every practice could benefit from this, even if they think they're doing an excellent job. There's never,
because they all do.
A different set of eyes on your practice to highlight those areas and make those recommendations. I mean, I can't imagine that any dentist listening to this wouldn't want you in their office, looking at those fraud prevention, and just frankly coding issues that really lose money, right? And loses money, and it's.
I've seen practices lose. It's not uncommon for me to find $2,000 to $10,000 a month in lost revenue. Some of that is just because they're doing the work and they're not billing it out. So that's one aspect. Another aspect is they're miscoding. So that could be an aspect. I did find in one practice about $40,000 a month that was consistently walking out the door. And this was a private practice. They did a lot of implants, and they did a lot of implant restorations. And for whatever reason, their insurance administrator did not understand that the abutment was a separate procedure. So you've got the crown and you've got the implant, but there's a connecting piece as an abutment that's a separate procedure. It's like the tires on your car. You can't not have that.
Pretty important.
Kind of important, yeah. You can't not have that abutment. I mean, there's, we could get into, well, certain manufacturers do it this way, but in general, you have to have a way to put the crown on the implant. That abutment is a separate procedure. It's a legitimate procedure code. It's a legitimate process. It's a billable service, and they weren't billing for it. They thought it was part of the implant. So $40,000 a month, that's a huge hit to a practice. So that doctor was really happy with me when I pointed that out. But again, that was a coding, not so much a coding error. It was just something they didn't know. You don't know what you don't know.
Right.
Okay? And that person learned it from the person before.
I love it. I love it.
So, there's just layers upon layers upon layers of things that are so important, and you don't know what you don't know. That sounds so cliche, and I wish I had a nickel for every time in 40 years I've heard that. But it's true. Even doctors that will tell me, oh no, we're good. My production's great. My AR is at 30, at 30 days and under, or 40 days. I don't have any outstanding. They're looking at numbers on a piece of paper. They're not looking at their practice in what kind of risk it could do. So once I do the recommendations and finding, if the doctor wants to move on with some sort of training, and I've never had one not
I'm sure
something at least, then we kind of stop the bleeding, talk about like the long game and how to get these protocols and train our team and get them protocols and procedures in writing. So many offices will tell me, I've already had a consultant come in, or, and they were either unhappy with the results that they got. They may have loved their consultant, but they were unhappy with the law. Or yeah, we did it for a month or two, and then we just kind of let it go. And I belong to several organizations specifically for consultants and speakers and things like that. And I have many dear friends that are consultants. And I think in the bigger basket, I probably fall into that consultant category. But I view myself more as a personal trainer, if you will, and a teacher.
Yes.
Every consultant is different. We all have our areas of expertise. We all have our strengths and weaknesses, which is why a lot of times we'll refer to each other. I am not an HR expert. I have consultant friends that are HR experts. Okay. I teach HIPAA and I can do an OSHA overview, but I am not an OSHA expert. I have consultant friends that are experts. They breathe this stuff.
Yes.
I have legal consultant experts. So we all refer and bounce off to each other. So
absolutely.
What I do is I like to get the doctors, like I said, let's stop the bleeding, let's treat the disease, get the bleeding stopped, and then introduce them to a way that they can manage that practice and get those procedures and those protocols and really define things using a network of experts. Not just me. You're going to get an HR person. You're going to get a legal person. You're going to get a practice, management person, let's say. You're going to get a communications expert. You're going to get these things. You're going to get a numbers analysis person. You get these things for so much less than you would spend on one consultant. And I can honestly say I can guarantee that.
Yes, and it's pretty tough to find.
Customizable to you on your time. And so that's really the end game, is let's not let this happen again.
I love it. So what is the best way to get in touch with you?
So the best way is you can pick up the phone and give me a call. I'm in California. What I do remotely, so I do it all over the country. Do my snapshot program actually after hours. I don't want to be disruptive to your team's flow. I do use a dedicated computer. Sometimes there's one stuck in the back somewhere and hardly anybody's on it. And if that works, I can get on during the day. If not, I work evenings, I work weekends. I work around doctor's schedule. Doctor doesn't work around my schedule. And so that's an easy way to do. So 209-222-0750 or Theresa at theresasheppard.com.
Excellent. And we will also
love to have a chat. Yeah, let's do a discovery call. They're complimentary. And see if we need to take your snapshot. My goal and my passion is really to keep practices protected, number one, and profitable, because doctors and team members don't realize you can be incarcerated for some of these things. That's the worst that could happen. The least that could happen is you could be fined. Yeah. You could have a license, maybe some sort of disciplinary action. And people think, oh, well, I'm just the office manager. I'm just the assistant. If you're culpable in that, you too are subject to all of these things, including incarceration. So doctors' names on the door, they're the ones that are going down. They don't even know most of these things are happening.
Right. That's the sad part. And it's so preventable. So preventable.
It is.
And your services are amazing. I will definitely include all of your contact information in our in the comments and links. And wow, Theresa, I learned so much. Again, every time I talk to you, I learn so much. I love it.
Thanks.
I think we
It's
should.
hard to kind of compartmentalize these things because like I said, I'm a teacher, so I could go on for hours and hours and hours
Well, and my
about these passionate subjects.
Like all connected. So it's where do you start and end with that conversation? But I love all the value you brought to us today, and we will definitely do this again. I appreciate it.
Thank you so much. And I appreciate your time, and thank you to your audience for allowing me to kind of bend your ear for a little bit.
Love it. All right, over and out. Have a great day.
Thanks, you too. Bye-bye.